Hello, we'll let people trickle in for a couple seconds here. Then we'll get this show on the road. Hope your day is going smoothly so far, wherever you are joining us from. My name is Katie Green. I'm a director of marketing here at Best Buy Health, and I'm going to get us started. I've really been looking forward to this session. I hope that you have too. We really have an awesome panel of experts who have truly been instrumental in leading the charge about what acute care at home looks like and can do by pushing the envelope within each of their programs. So a couple of just quick housekeeping things before I turn it over to Ben here, who's going to moderate our discussion. We are going to do our best to save some time for questions at the end. We have a lot of content to get through, but please use that Q&A box to send us any burning questions you have. And before anybody asks everyone's favorite question, we are recording this session and we will share that out with you in the next day or two. So moderating our all-star panel today is Best Buy Health's Chief Medical Officer, Dr. Ben Zaniello. Ben is a practicing infectious disease doctor who previously served as the CMO of Point Click Care and held several leadership positions and advisory roles within Providence Health. So with that, Ben, I will turn it over to you.
Howdy, howdy. I always worry that when you talk about it being recorded, the panelists are always like, maybe I'm not going to talk about this, but that's all right. So my main job here is the facilitator. I'm super excited. We have an all-star panel that's going to talk about what they're doing in this space. So I'm going to try to talk as little as possible and really just facilitate. So let's actually just start with intros. Kristin, I'm going to start with you. Can you talk a little bit about who you are and what you do?
Sure. Thanks, Ben. My name's Kristin Bloom, and I'm the Assistant Vice President of Hospital at Home Clinical Operations for Virtua Health. I'm an emergency department nurse by background. And I have a passion for patient flow and capacity management. I currently am one of the leaders supporting Virtua's care at home strategy, as well as their virtual care clinical operations. And I have oversight of our hospital at home program, our care after discharge program, our inpatient virtual nursing pilot, our remote longitudinal monitoring program, and our centralized staffing office with our agency contract management.
It sounds like you're busy.
Yes.
Taki, why don't you talk next?
Absolutely. It's a pleasure to be here. And Katie and Ben, thank you so much. And Kristin and Denise, it's a pleasure. My name is Taki Michaelidis, although it says Constantinos, everybody calls me Taki. I'm an internal medicine doc by training, a hospitalist, and medical director of the UMass Memorial Medical Center Hospital Home Program. So it's a pleasure. Looking forward to this.
Awesome. Denise, last but not least.
Hi, everyone. Thanks for joining and thanks for inviting me on this panel. My name is Denise G. I'm a minimally invasive and bariatric surgeon by training. And in this context, I am the clinical director of surgical services for MGB Home Hospital.
I suspect you also are very busy. Okay, great. So let's plunge in because we don't have a lot of time and I know you all have a lot to talk about. So we're going to start with just an overview of each of your programs. So Taki, why don't you start?
Sure, sounds great. So to take a step back for the moment, for those who are less familiar, UMass Memorial Medical Center is a safety net nonprofit medical center in the central part of our state. We care for a quite disadvantaged population and are both the primary care providers and the tertiary care providers, the level 1 trauma center, the NICU, the high acuity tertiary care, the transplant center in our central part of the state. We've struggled with a capacity challenge in our medical center for years. Frankly, I would say probably decades. It's not uncommon for us to start a morning with 100 to 120 patients awaiting an inpatient bed in our emergency department. And there's obviously patient experience challenges with that with that state of affairs. And so we launched our home hospital program in August of 2021. We're about 3 years into the program, so I would say we're out of the toddler phase. We're walking, we're talking, a lot of things are going well, still many opportunities to do better for our patients. And now we're adding on additional services as we go. So we're working to turn into more of a 24/7 admitting shop versus being a 14 to 15-hour admitting shop. And then we're layering on dedicated surgical care pathways on top of our classic hospital service. So we launched our post-cesarean section delivery pathway a couple of months ago. We're in the process of getting close to launching a post-sigmoidectomy care pathway where folks will come directly to us after their procedure, and continuing to add and layer on services. We're doing blood products in the home. We're doing a whole bunch of different quite neat things to try to expand everything we can provide so that we are a hospital at home in every way, shape, and form of the word. So that's kind of where we are today. So looking forward to hearing more from Denise and Kristin.
Awesome. Yeah, again, already the framing for this is the three of you have a lot going on, and particularly in the acute care at home space, which I think is exciting for everyone. Yeah, so Kristin, why don't you talk about what you're doing next?
So I'm going to talk a little bit about our care after discharge program specifically. And this is a program that we launched in April of 2023. And to date, we've treated over 2,100 patients. And really the vision of this program was to create a bridge between the acute care setting and the ambulatory setting. We know there's like a gap that occurs when patients are transitioned out of acute care. And really the intent was to encourage earlier patient discharge, some more support reduction in readmissions, and promote our network integrity.
Amazing. Denise.
So I'll speak more towards our surgical home hospital. So our home hospital in general, broadly speaking, has been in existence since probably around 2017. And then more recently, last year, we became a system-wide an MGB enterprise home hospital. And that's when we formally created this position of mine, which is Clinical Director of Surgical Services. And have been really laying the foundation for admitting post-operative surgical patients to home hospital, as well as non-operative surgical patients or surgical patients who show up in the emergency room or have other types of clinical problems. So we've been admitting surgical patients for a while now, but it's really looking at how we can expand and grow. We started with post-bariatric patients, and we're rolling out new pathways, including colorectal, similar to what Taki had alluded to, as well as other capabilities such as managing, wound infections, return of bowel function. We have non-operative pathways like non-operative diverticulitis, small bowel obstruction pathways, and hope to grow even more in the future with other pathways coming down the pipeline.
That's actually interesting. So you just talked about already how you're expanding. And of course, Taki, I feel like you guys are already doing all the things. So maybe I'll go back to you, Kristin. Can you a little bit talk about what you think you're doing next? We'll spend a little bit time on kind of what you're doing now and going into that use case. But since Denise kind of already started that discussion, what do you think is next on the horizon?
Yeah, sure. So I guess I'll start with the fact that when we launched Care After Discharge, we launched it at one of our 5 acute care sites, and we really looked to expand that quickly across all 5 sites. So we were fully expanded by the end of last year, and we were really targeting inpatient and observation patients in that medical, surgical, critical care area. That we're transitioning out of acute care into the ambulatory setting. I think there's no shortage of expansion use cases for care after discharge. And really, when I think about what the premise of it is, there's the ability not only from acute care into the ambulatory setting, but you can also use it in terms of admission avoidance, ED avoidance, where you're transitioning from your ambulatory setting. And this is used as like a mode of continuous monitoring and access to a nursing command center so that you can avoid admission altogether.
I think anybody that's on coming from the kind of capitated health plan, ACO, managed care world is that's always been a bit the holy grail, which is how do you, it's one thing to accelerate discharge and or to ensure a safe discharge, which has been primary focus of care at home programs, but actually not having people enter the emergency room or at least not have to be admitted at all, I think is such a wonderful focus. I was excited that you're doing that. So let's actually shift into just looking at time, a little more detail on like your particular use cases. So Taki, I know that you guys are doing postpartum work and there's been a lot of interest in that particular area. Do you mind just talking about the kind of details of what you're doing, the population you handle, how you bring them in, how you've rolled it out, et cetera?
Absolutely. So I would say a couple months ago, our team had a deep dive looking at opportunities across the system where we could provide capacity support, high quality, safe, patient-centered care. And our cesarean section pathway emerged from that discussion. And so just like our broader medical center struggles with capacity, our mother baby center also struggles with capacity in the central part of our state. And so the question was, how can we serve moms and babies to provide the same high acuity care in the home that they would normally have in the mother baby center, while working through some very nuanced issues around, we're not pediatricians. We need it to be boarded appropriately. We need to make sure we have malpractice coverage. We need to think through the safety and escalation care pathways, all these very nitty-gritty pathways that we have to work through. So we launched a number of months ago where folks will come in, moms will come in, have their cesarean section, and we'll take folks home on typically on the morning of postoperative day 2. We're not caring for the babies, so babies have to meet certain discharge milestones in accordance with their pediatrics guidelines. And then we'll bring mom home with us. We'll care for mom and for typically about 1 to 3 midnights of care with us going forward. And patients have been doing great. We're still early in the trajectory. We started very conservatively from a selection criteria perspective. And now we're actually liberalizing those criteria as we've seen very strong outcomes. We've seen really no safety events, no mortality, no readmissions, no escalations, and patient satisfaction has been very, very high. So we're now going to be liberalizing in particular our criteria around hypertensive disorders of pregnancy, where we'll start to take folks who had preeclampsia but are no longer requiring active management of their blood pressure. That's just one example. But I think as all of us have gotten more comfortable working together as adult hospital medicine physicians, as well as obstetricians and pediatricians, we've seen just very solid, I would say fantastic outcomes. And so we're going to expand that population.
Let me actually ask you about this. And I love that I know you're an internist and I'm an infectious disease doc and like the treatment of children terrifies me. How did you work with the specialist in that regard? Like, it sounds like you've had great engagement and involvement. And I think this is really important for a lot of our listeners because so often these programs, and I know yours did as well, starts fairly general. And I think, Denise, you talked about MGB where you're like looking at acuity more than you're looking at a particular use case or specialty. So can you talk a little bit how you even approached these specialty providers, how you engaged them, how you got them over the hump of care at home, that sort of thing?
For sure. And, I'll share just a quick plug, A, for collaboration, and then B, for confident generalists. And I think that's when we recruit our physicians and nurses. And Kristin, it's part of the reason why we've recruited many emergency department nurses who are phenomenal at this work, is that they are confident generalists. They can do anything, nothing scares them. They love caring for patients, and they're super oriented around the social determinant challenges that we sometimes miss in the brick and mortar that we can then laser focus on in the home in particular. So collaboration, for sure, confident generalists. And then in terms of the actual collaboration itself, really the interest came from our obstetrician colleagues. And so they were excited. It wasn't coming from us going to them. It was from them coming to us saying, we think we can work together. And from our hospital medicine, hospital service perspective, me as a hospitalist and a medical director of our hospital home program, we simply asked ourselves, what do the patients need and can we meet those needs? in many hospitals across the United States, hospitals care for lots of postoperative patients, and many services, and same thing with our post-sigmoidectomy pathway. Lots of hospitals are caring for folks who come out of the OR in other hospitals. And so we simply had that discussion with our surgical colleagues. They felt very comfortable with the services that we offered and provided, and we seek their input all the time, for sure. I am by no means an obstetrician. We are very, very grateful for their support. But what we also find is that on postoperative day 2, most moms are doing really well, and they look and feel sort of like other patients who have had other surgical procedures that we're used to caring for routinely.
Oh, that makes sense. Okay, you've maybe lowered my temperature and fear a little bit about that.
Okay, good.
Well, obviously, I work for Best Buy, and that's a little bit the framing behind all of this. So we approach all of this from a partnership perspective, from as a technology, as platform, as software. Can you talk a little bit about the technology? You don't have to do a Best Buy plug here. You can talk about all the stuff you're using, your EMR, et cetera. But can you talk about that kind of technology side of it, what you're using, what you're monitoring with it, that sort of thing?
For sure. And Kristin, Denise, would love to hear your perspective too, as you thought about health equity and technology in particular. For us, this was a design principle from months, really frankly, even years before we launched our program, which is how do you design with intentionality a program for health equity oriented around caring for every population who arrives at your medical center, whether it's the emergency department or the mother-baby center, for our cesarean delivery pathway. And a big chunk of that equity-oriented work is around making sure that patients don't need to have anything in their home. And so for us, the Current Health Partnership allowed us to bring internet, allowed us to bring translation services, allowed us to bring the monitoring remotely to the home. And so that's been a real key element for us. We speak 250 languages by video and another 50 to 100 by audio where we don't have video connection. And so we really have not had any exclusion criteria around those elements. And so for us, that's incredibly important. From a medical center perspective, when we look across our payer population and our home geography and language and all the demographics of our medical center, we find that our demographics are identical in our home hospital program across programs as they are in our brick and mortar, which is exactly what we want to see. And we also find that when we look at patients in our emergency department and our mother-baby center, with 1 or 2 payer exceptions, we're able to consider about 90 to 92% of all payers in our medical center. And a part of that is the technology. So thank you to our current health partners for sure. And a part of that is really aggressive work in terms of partnerships with our payer partners, and building those contracts, getting them launched quickly and saying, the care is better, it's more patient-centered, we're generating 30-day savings. This is a win-win-win-win, let's move forward. So thank you to our current health colleagues for sure.
Yeah, but let me understand that a little better. So, and I love that you brought out the health equity component. We were going to get to that a little later, but since you brought it up, are you finding with this generalized population that the health equity issue is less of an issue because you've brought in these payer partners? You're actually finding that they have, generally speaking, the home has not been an issue for the delivery of care? Or are you finding that you are having to do extra to manage that issue, whether it's technology access? It sounds like you've covered the language piece. I'd love kind of a little more of your thoughts on that.
It's a great question, and there's multiple layers for sure. And so I'll be a little simple, and then would love to hear others' perspectives as we learn a little bit more about the other programs. Stepping back for the moment, the vision was always a full service hospital at home. And so, when a patient comes into our emergency departments, we don't ask that patient, do you speak Portuguese? If you do, we can't serve you. We care for everybody in the community. And that was the vision around our home hospital program. And that still today remains the vision around that home hospital program. And so I think that's why we're very proud around the demographic alignment between our program and the brick and mortar. And so I think to your point, Ben, a lot of it is designing services, layers, and capabilities that allow you never have to worry about a particular element. So we don't have to ask things like, do you have a caregiver at home? Because we bring in a home health aide, we bring in a PCA to support activities of daily living, we bring in the translation services, we bring in food, et cetera. And I think that's an area that CMS in particular is really oriented around across programs, and one that we have continued to focus on.
That's amazing. Let me just ask you one more question, and then we'll give the other panelists a chance to talk about what they're working with. Have you found, did you have to make a business case for those resources? I mean, I hear about those resources and they sound amazing, and it sounds like you had them kind of early on. Was that a hard case to make? Were they already present? Like, how did you get from, again, what sounds like a fully formed program?
It's at the very, very early stages. Of course, there was a thoughtful strategic plan around the vision and business plan for home hospital. However, that said, we are a safety net, health equity oriented health system in the central part of our state. And so once you elect to move forward with this care model, the vision is always, how do we democratize access to everyone who needs it? And I would say that when we looked at the business planning for this, we said to ourselves, holy cow, it's a $2.5 to $3 million spend per brick and mortar bed build. 10, 15, 20 years in planning. Interest rates are extraordinarily high these days. It's not an easy time to go out there to the capital markets and raise dollars. We built a 20-bed unit in 6 months. That's the safest, highest patient satisfaction, lowest mortality, lowest readmission unit in our whole health system. And that took, 6 to 8 months or so. So from a value proposition perspective, it was quite compelling to the C-suite for sure.
Yeah, it sounds amazing. And I do love your point that if you start with kind of access, health equity as part of the formation of the program, then it's a little less about how do we fix that later on? How do we work that you actually make it part of the DNA? And I think that sounds like a critical part of your success. Okay, switching gears a little bit. Denise, I'd love you to talk about the post-surgical use case, which sounds a little different here, and what you've seen with it, again, relatively newer, et cetera.
Great. Yeah, I think, a few years ago, we had, I was performing bariatric procedures, and our home hospital program was had not had a formal surgical pathway. And I had talked to some home hospital leadership at the time to think about, how could we care for some of our bariatric patients and not take up a bed. This is before COVID, this is before major, capacity crises. And we came up with a pathway to try to just look into this and see whether or not this was feasible. My breast surgery colleagues were doing something similarly. And we were able to offer care to patients safely in their homes postoperatively, and started to slowly grow that. Then COVID hit. And so when COVID hit, a lot of kind of, the ground rules changed a bit. We actually at that time expanded to some urologic procedures and some other surgical specialties where we're performing these operations and trying to figure out how best to care for patients in a kind of out of the bricks and mortar hospital. We had looked into, hotels nearby and other kind of creative ways of helping care for patients. And then when MGB kind of reinvented home hospital, so to speak, and kind of looked across the system, we really were based upon the principles that, Taki kind of elucidated, which is offering the same exact care that you could obtain in a bricks and mortar hospital, but being able to offer that in patients' homes. And from my perspective, specifically for surgical patients. And so we really expanded bariatrics. We used a lot of the lessons learned. It's a very iterative process. There's so many layers to it, from, how do you communicate this, just to surgeons and to patients, but then also your preoperative staff, your clinic staff, your postoperative staff, kind of having that whole team on board to support patients and understand this new model, this innovative new model of care, and also making sure that it's equitable and that you have patient safety at the forefront, et cetera. So we did that with bariatrics, and we started thinking more broadly about what other surgical pathways could be built. The non-surgical pathways for surgical patients, like small bowel obstruction, where patients can sit on the wards for days and days and weeks, waiting just to see if they pass flatus, right? So that could happen in the comfort of a patient's home. A lot of the diverticulitis cases where patients are relatively stable, they're on antibiotics, and you just want to make sure that they're doing okay. That's another pathway. So we started looking at those, and then started talking to surgeons on the ground who are intrigued by our model and interested in looking into what pathways might make sense. So, we started talking about with our colorectal colleagues, some of our orthopedic and neurosurg colleagues, and looking at spine, as well as others, to try to think about what the next step is and what the new patient populations we can accommodate are. I'll pause there and see if you have other questions.
Oh, I have so many questions. Like, again, I love that you're bringing this specialist perspective. And again, it sounds like you were thinking about this for a long time. So it's not so much that somebody approached you and was like, hey, what do you think about bringing your patients for care at home? But what, as you rolled it out, and what has surprised you the most? And is it something that was very different from the hospital care model, or something you saw differently?
I think that it's just a different way of thinking about how to care for the patient and getting engagement from surgeons and talking to them. And I think what I've found is, surgeons, after, it's a little bit different, right? Because there's no surgical hospitalists in our model. So the surgeons remain the attendings of record for their patients, which, at least in our, our hospital, our system, most surgeons still want to be care, they still want the patient kind of under their care, even if the patient's being cared for in-home hospital. So it's trying to figure out kind of what that model looks like. So we have a surgical lead PA who kind of manages across our service, as well as other APPs that we have hired to kind of round out that that kind of level of care. It's communicating with surgeons to ensure that, we will be able to continuously communicate with them and let them know how the patients are doing, making it easy for them. So it's no extra work for them to have patients admitted to the home. And so that's been, a lot of thinking through and working through. And then it's just looking at different specialties. And, what I've found is that if you talk to surgeons, there are very innovative surgeons who are interested in this kind of thinking. And so if you find a champion in these various specialties who are willing to work with you, you can actually kind of, the sky's the limit, right? To design what this might look like, what the key stakeholder concerns are, but yet how to address those and still work within this home care model. And we've had a lot of great engagement.
I think that is a great takeaway point, which is that kind of identification of the innovative champion. It's not so much that not everyone is interested in doing it and would do it, but it's identifying that person that probably is willing to spend the extra time and work to translate it a little bit to their specialty.
I think the translation, exactly right. I also think that, even in the last year and a half, we've gained even greater traction with the surgical community just by understanding what home hospital is and what we offer, even from their medical colleagues, and just kind of it's changing culture, right? But then within the surgical world, surgeons seeing that patients can be cared for, or their colleague's patient was admitted to home hospital and their experiences were great. And so that has also changed the prevailing kind of sentiment towards admitting surgical patients to home hospital.
Awesome. Well, thank you. So we actually a little bit just talked about kind of one specialty side, one particular use case around postpartum, and then talking about working with surgeons. So Kristin, I'd love for you to talk about, it sounds like you guys have framed it a little differently. You're talking about post-discharge, which can be a lot of different reasons for discharge or reason for their hospital admission. Can you talk a little about that?
Yeah, sure. So we really did birth our program out of learnings that we gained from providing care in the home in our hospital at home program, right? Going into the home, we identified opportunities related to medication reconciliation, transitions pharmacist support, appointment navigation and scheduling to ensure successful follow-ups, access to a 24/7 nurse-led command center. We saw the benefit of that in hospital at home and how we could leverage that on our path to scale, not only in hospital at home with care after discharge as well. And then really just having those benefits of in-home clinician assessment, having that clinician be in the home to see what the living situation was and what barriers really existed to adherence and treatment plan and how we could remove those barriers. We defined our scope and eligibility for our program, again, really from the starting point being hospital at home. So we were taking medical surgical patients into our hospital at home program, and we looked to really create that path from inpatient and observation discharges from the medical surgical critical care areas into care after discharge. It felt like it was the easiest use case to start with, and we since entertaining other use cases that you had heard me talk about at the beginning related to ED, treat and release. So now we just kicked off this week a pilot in our emergency department where we're looking for patients who are really like that low risk for congestive heart failure admissions. And instead of admitting them, we're transitioning them into care after discharge and then connecting them to the CHF clinic for outpatient follow-up. And the nice thing about a program like this, in the state of New Jersey up until the beginning of this year, we did not have legislation that supported hospital at home. We were operating under the CMS waiver. And so we were limited in hospital at home with payers related to Medicare and some Medicare Advantage. But in the beginning of the year, we had legislation that was enacted that supported us taking Medicaid patients and some commercial payers as well. So that's been really excited related to our hospital at home program, but with care after discharge, we're not payer limited at all.
I appreciate you bringing up the reimbursement side, because I know that's what a lot of people think about this with this program. And again, COVID was mentioned earlier as the big change maker and the hospital at home CMS for Medicare, but obviously wanting to do it for more than just Medicare programs, you have to have alignment with either your payers or within your state or both. And I think that is really important here. What I did actually want to ask you for a little more detail on, because you have, and I recognize it's not all comers in the post-discharge, how do you identify the kind of right patients for it? And you talked a little bit on the ED side with CHF, but how are you doing that within the hospital to say you are appropriate for this post-discharge pathway?
So if you remember back to what I had said, our vision was related to the outcomes that we were hoping to achieve. We talked about a reduction in length of stay, shortened length of stay. And so what we're looking at is our clinical estimated date of discharge. So patients who are listed as a clinical estimated date of discharge of 1 to 3 days, we're really looking at those patients to evaluate and have those conversations with the attending physicians around, do they really need to stay, for the dose of PO prednisone, or can we discharge them today and watch them in a program like this? So it's really creating that clinician comfortability to ease discharge a bit earlier, but we work off of clinical estimated data of discharge. In the beginning, we worked off of that solely, but at this point, in the last 6 months specifically, we have seen it shift from a pull system to really clinicians are pushing into the program because we've proven the value.
So just let me understand that pathway and kind of say it back to you. So you'd be capturing in your EMR from the clinical team when they think that person would be discharged. And then initially you would look at a particular patient and say, could we discharge them earlier if we enrolled them in this program, and then have a dialogue there?
Yeah, so what we found with hospital at home was we had nurses that were screening patients to enroll in hospital at home. And quite frequently, we found that we were having conversations about, is this somebody who needs hospital at home, or is this somebody who we could really push discharge on? And so those conversations haven't really changed. It's just expanded because we're no longer payer limited with care after discharge.
And then that transition, which I think seems miraculous, where providers are now coming to you and saying, hey, could we discharge my patient on this program? What have they given you kind of reasons for that greater engagement, like what they've seen or what they've experienced with other patients?
Yeah, so I think we have engaged our hospitalists to help support coverage of hospital at home and care after discharge. So our hospitalists that work within our hospitals are also helping to cover these programs. And I think it's through that engagement that they're really seeing the benefits of the program. In addition to that, patients who we would not have normally captured in hospital at home due to the payer limitation, we capture in care after discharge, they're having that hospital at home experience with the command center, the in-home clinician, and they're loving it. You heard Taki talk about that patient experience and the outcomes. These patients, when they come back to the hospital, that's what they're asking for. So it's really hard to argue that from a clinician standpoint when your patient is sitting in front of you saying, this is what I want, and this is where I want to go.
Oh, I love that. Of course, that's the most virtuous, no pun intended with the name of your health system, but virtuous circle that patients are actually requesting it through their providers. Actually, you brought up something there, which is just that one of the goals of your program, kind of the outcomes you're looking at, was reducing length of stay. I'd actually love maybe each of you to talk about what were the kind of outcomes that you were looking for going forward. So what is your measurement of success? Denise, can I start with you?
Definitely. So are you saying with regards to length of stay, or what are our overall measurements of success?
I think if length of stay is an important one, sure, but anything that you're looking for to measure success, both internally and externally.
Sure. So I think for length of stay specifically, and again, I'll speak from the surgical standpoint, it's one of the things that we need to make sure of is that you don't admit a patient to home hospital and then, it's easy to just keep them in the home and keep them for another day and see how they're doing. And that could easily kind of build up length of stay overall. And so it's kind of getting everyone on board and comfort of knowing that, a patient who might still have a little bit of nausea and a little bit of pain we otherwise would have discharged from the hospital, and that they get better within the next 24, 48 hours, and that it's okay to discharge them. So I think making sure that our average length of stay for post-operative patients is the same from bricks and mortar hospital versus home hospital is a priority. And I think has not been an issue in the surgical use cases at the moment, but something that we continuously monitor. I think other measures of success from a surgical standpoint, right at the center, obviously, patient experience and quality of care, obviously. No one would argue that. I think that's extremely important. I think provider kind of experience also. So for surgeons, for, other providers, making sure that that's high quality and also, similar to how they would manage patients in the hospital. And then obviously, as everybody's alluded to, making sure that financially, obviously, it makes sense and that kind of is in the background. But I think patient and provider experience are key.
How are you doing that today? Recognizing we're early doors here, are you thinking, is it anecdotally, is it survey related? How are you going to capture how the patients feel about it, the providers feel about it, that sort of thing?
Yeah. So first of all, it's like the outcomes, right? So making sure that readmissions and length of stay and return to, escalation, et cetera, making sure those numbers are monitoring those numbers. And then with regards to patients, we do have surveys. We've started doing studies in the bariatric population to see how patients feel about the experience and what their take is on the entire home hospital stay. And our group, from a broader home hospital perspective, has done a lot of research into this and demonstrated that patients generally have a much more positive recovery experience at home. And then from provider perspective, because the surgical program is still somewhat early, so we haven't done any large scale studies on that just yet, but definitely from anecdotally and smaller kind of survey results, this provider experience has been excellent as well.
Awesome. So, Taki, you actually talked about this very quickly before. You had just said you have already measured it to ensure that a lot of this is at parity or more with the hospital. Can you talk a little bit how you captured that data and what are the outcomes you're focusing on going forward?
For sure. And I really like, Denise, your point that, this is acute care. This is acute care, and we have standard and pretty thoughtful generations of quality metrics that we're all adhering to on the brick and mortar side. The patients that Denise was chatting about, that Kristin and myself are also chatting about, who are in this CMS waiver home hospital programs, we're all beholden to CMS to execute on the same quality metrics that we do within our brick and mortar units, because these patients otherwise would have been in those brick and mortar units, as well as to execute against the quality metrics for the CMS waiver, like escalations, et cetera, like that Denise had shared. So we're very, very strongly oriented around those measures. I think there are some kind of interesting, I would say, kind of gray zones that we're continuing to explore with our regulatory partners, with our measurement partners. A group of us in the hospital home users group, and a big plug for them. They do great work for sure. The Quality Improvement Council was meeting with the CDC just a few days ago, talking about how when a C. diff infection occurs in the home hospital program, today that is not reported as a hospital-associated C. diff case. That's reported as a home or outpatient C. diff case. And that has some really interesting implications for how we track hospital-acquired infections. It could paradoxically mean we're underreporting hospital-acquired infections in the hospital home if there are higher rates of hospital-acquired infections in hospital home, or it could mean that we are concentrating essentially or undervaluing the benefits of home hospital if we're reducing hospital-acquired infections. So I think there are ongoing discussions with quality groups, with surveillance groups, with regulatory groups to make sure that we are doing what the original intent of the surveillance was across all of these metrics. And it's been a really, I think, one of the things I love about home hospital is that the outcomes are so strong, the community is so strong that we come together and say, how do we get to the right answer for our patients? Because we are seeing those quadruple aim wins for sure.
Well, Taki, obviously, by mentioning C. diff, you just spoke my love language as an infectious disease doc. So I appreciate
I've never heard that before, Ben. I love that.
C. diff is definitely my love language. But that said, I think you touched on a little bit the gray area, and I think not to quote Donald Rumsfeld, but I think one of the things we've all faced in care at home is the unknown unknowns, the challenges that we weren't aware that were going to become challenges. And I think one thing that may be helpful to people tuning in is maybe talk about what your biggest challenge was, or one of the challenges, and how you met it, because I think there's a lot of interest in starting these programs, expanding these programs, but they run into things they didn't necessarily expect. I think a lot of people would be enthusiastic to hear that we're not tracking C. diff at home, given the feedback I received within the hospital setting, but that's a side note. So Taki, why don't you start there, and then I'll give it to the other two.
For sure. And I'm Kristin and Denise, I'm looking forward to hearing your perspective on this. I would say that my number one perspective for any group that is considering developing, deploying and scaling a home hospital program, that it is one of the most rewarding things you will do. I feel so grateful every day to wake up and care for patients in our model with a team of passionate caregivers that I have the pleasure of working with at our medical center at UMass. That said, it is extraordinarily hard. You are changing hearts and minds of caregivers, docs and nurses and APPs, and every single person who's used to caring for a patient in a brick and mortar, and you're telling them actually that patient doesn't need to be in the brick and mortar and they're going to do better with us. So we're still 3 years into our journey. That change management journey is still very early. We still have folks who are quite skeptical, and that's okay. We will get there eventually. But I will say to Denise and Kristin's earlier points, one of the things that's most rewarding is when the patient comes back a year later and they're in the emergency department and they're telling everybody that they can find, I am going to home hospital. Where's the home hospital team? I want to talk to them. That is incredibly rewarding. And we're just starting to see, I would say, the wave kind of crest where enough patients have had exposure to us in the last 3 years that when they do come back for any reason, 2, 3, 4 years later, hopefully much later, they already know about us and they're asking for us.
Well, that was a very positive note to end on the kind of challenges, your answer to the challenges piece. Kristin, can you talk about the challenges you faced or one in particular?
I think probably the biggest challenge, as Taki said, is change management. But in addition to the change management, it is specifically for care after discharge, it becomes the connector between the acute care and the ambulatory setting. And so creating that seamless experience for the patient so that they don't feel like it's a bumpy ride to each next phase of care. You know, being able to work with our home care colleagues and transitioning from care after discharge into home care, transitioning from care after discharge to our specialist's office or primary care, the CHF clinic, like that has been probably the most challenging in addition to the change management, just solving for how we create that ease, not only for the patient, but also for the clinicians.
I love that you brought that up because I think from a continuity of care perspective, we would hope that if that classic transition from hospital into home has always been something we've struggled with in healthcare, how to make it as seamless as possible, leaving the inpatient to the ambulatory environment. So I think back to that unknown unknowns, you would think that if your discharge program is in the home, that you have, jumped that step or made that step easier, but still they're moving from a hospital managed program after that into a ambulatory, the rest of their care. And I think kind of thinking that you have to ease that transition and actually actively work on it totally makes sense to me. Denise, what are your thoughts on challenges?
As everyone's alluded to, I mean, I think changing, and I, alluded to earlier, you're changing culture. And so I think that is a challenge, although I will say that the flip side of that is that if you're working with, a strong team and you have leadership buy-in, which sounds like at all of these institutions, there's leadership buy-in, with time and you proving that, you have a great product and patients are happy and providers are happy, you can overcome that. But just to brace for that and also to make sure that you surround yourself with a strong team. So for us, our surgical team is, from all around, like all different role groups within home hospital, we have a really strong team that helps kind of with some of those challenges of changing culture. I'd say from a surgical perspective, the other piece to keep in mind also is insurance and working with insurance companies and what qualifies as, what's reimbursable, not reimbursable, which patients qualify versus not. And it depends, with the operation, it depends with the insurance company. So not that that's a challenge, but that's something that, I learn something new every day in this job. And so that was something that you would think would not be an issue, but is something that you definitely have to keep in mind and look into as you bring on new surgical service lines.
Yeah, I guess that doesn't surprise me necessarily that given reimbursement is so, for better or worse, core to the practice of healthcare, that reimbursement issue would, as you think about different use cases, as you think of managing things differently, that it would come up. So we're collecting questions from the audience. As they're doing that, as kind of the last prepared part of this, I'd love for you guys, if you have one kind of on hand, to talk a little bit about a particular story, whether it with a patient or a provider or even a caregiver that you've experienced. I think particularly after we've brought up reimbursement, I think it's really really important to bring it home and talk about that, how it makes people feel. So, Kristin, why don't we start with you if you have one in mind?
Sure. So I'm just thinking about a patient who we frequently had in our acute care bricks and mortar and transitioned into our care after discharge program, it was recurrent. Patient continued to come back to the hospital for IV antibiotics related to a cellulitis in a lower extremity. And when we got the patient into our care after discharge program and we had in-home clinicians going out to perform that assessment and get them connected to our current health monitoring equipment, we figured out really quickly that what they were doing in their home, the chair that they were sitting in, the seeping of the wound into that chair was predisposing them to just not really ever getting better and continually needing to bounce back. So it allowed us to see into what we were discharging them into and to take steps to mitigate having them return to the hospital because we were able to identify that.
That is both a terrible and wonderful story. So thank you. Taki, how about you?
For sure. So this is sort of a really fun and also a two-edged sword type of story where maybe a couple of weeks after we launched our post-cesarean delivery pathway, I got an email from one of our surgical colleagues, a vascular surgery attending, who said, I'm having my cesarean section in about a week planned. Can I come with you folks? And, 2 weeks into the program, your heart flutters a little bit and you say, holy cow, yes, of course, we'll reach out and speak to you. She had a great experience. And actually, if you Google, she was on CBS News with her lovely little one just about a couple days ago, talking about her experience in our program and what it was like to go home and be cared for in the home environment. So I tell that story just because it's so rewarding. I also am a little worried that our audience might think that this program is only for vascular surgery attendings having their cesarean section delivery pathway. I promise you it's for everybody, but it was a really deeply rewarding story. So please feel free to Google that.
Yeah, well, actually, I think Katie or someone can get that in the chat because it is lovely, but you're right that it's definitely a particular type of patient and we would like to be more all-comer. So kind of finishing with you, Denise, any kind of anecdote that you'd like to share?
Two quick anecdotes. The first one is, in general, when I'm seeing post-operative patients and I just start out like asking how they're doing, pain, nausea, the general kind of pure surgical questions, the number of times that patients volunteer even before I would get to it, that the home hospital experience was excellent for them is very rewarding. They'll bring that up even, before they tell me how they're doing with their actual operation. So I think that is a great story. And similarly, from the provider side and building upon what Taki said, we have certain surgeons now, and again, I'm speaking from a surgical perspective, who reach out and want to engage with our team and say, I have a patient who I think would be great for home hospital. And in the very beginning, it was more crickets, but now to have more and more traction, have surgeons actually reaching out and say, I think this patient would be great. It's a little bit of that push-pull phenomenon, the question of, when does pull become push? And so that's really rewarding as well.
No, that's amazing. And I love in some ways how different all of your stories were, the different perspectives on it. So I love that. So fortunately, some of you, there's been tons of questions and our panelists that are much more gifted technologically than I am have been answering them as they've done so these questions. So I love that, but we do have a couple more minutes. It looks like Katie has come back on. Katie, maybe we have time for one or two audience questions that people haven't gotten to yet.
Yeah, we've got a few that I think we have time to get to. One I want to toss over to Kristin, which is, can you say a little bit more about how the reimbursement structure is working for the post-discharge use case?
Sure. So we built our care after discharge program like a mobile physician practice. So it is essentially, we are billing as a specialist telehealth visit. They transition home on day of discharge. They have a hospital at home technician who's a paramedic actually meet them at the house. They do an in-home assessment, some medication reconciliation with the virtual nurse as well as the patient and family. And then that next day, we've monitored them the whole time that they've been home. That next day, they have a telehealth visit with one of our hospitalists. which we're able to bill for. But truly the value prop of the program is recognized in the reduction in readmission, as well as the increase that we're seeing with our new Virtua PCP referrals, as well as our new Virtua specialist referrals as well.
Cool, thank you. And then Kristin, one more for you. The staffing component of this this program, is that your hospital at home clinical monitoring staff, or yeah?
It is. So that I kind of alluded to our path to scale and what we needed to do. So with hospital at home in the beginning, we had infrastructure set up to support that program from a clinician standpoint, nursing standpoint, command center standpoint. And we knew with the payer limitations that we were just never going to get to the volumes that we needed to support that infrastructure. So we built the care after discharge program off of the hospital at home, and it's the same team that cares for both patient populations. That was definitely a learning curve, specifically because it's all inpatient clinicians. And there is definitely a difference between inpatient and ambulatory. So it has been a learning curve for us, but it has been phenomenal experience because we've learned so much in hospital at home, and we've been able to take a lot of those learnings and put them into practice with care after discharge.
Very cool. Similar staffing related question for Taki and Denise both. Who is doing the in-home visit component for the postpartum and post-surgical patients? What type of staff?
Go for it, Denise.
So right now the patient we'll talk about the post-operative patients when they go home. We have a nurse or a paramedic who meets the patient at their home to see the patient and monitor vitals and get labs, etc. Similarly, the next day, the same, but we do have an APP, a PA, who also checks in and makes sure, kind of oversees that visit. And then the other layers, virtually, the surgeon or the surgical team also can check in with the patient.
For sure. Would echo a lot of what Denise just shared. In our program, our paramedics and nurses are in the home caring for the patients. Our providers are actually purely virtual. There are, of course, certain moments where we will transfer folks where they need an in-person evaluation. Rheumatology wants to tap a knee, or our surgical team needs to drain an abscess, and we have certain touchdown spots in our brick and mortar to do that type of work. I will say that this actually gets back to, I think, the earlier point around confident generalists, where our nurses and medics are very, very experienced. And in our post-cesarean delivery pathway, they actually went through a re-onboarding back in our mother-baby center as well, because that's obviously a particular skill set. It's a very, very important and advanced skill set. And so they went through further training before we launched our cesarean delivery pathway from the nursing team in the mother-baby center.
Cool, thank you. And then I'm going to modify one question somewhat selfishly. All of your programs have done an amazing job marketing yourselves, right? Marketing your the care that you're able to deliver out in your communities to patients. Taki, I know you mentioned at some point your program gets to the part of its life cycle where you have patients requesting you because they need acute care again. But for those of you who are joining us, whose programs have not yet reached that kind of threshold of crossing over from pull to push, what is one thing that each of your programs has done that you believe kind of helped you get to that point? Building that awareness, both on the provider side and or on the patient side. Denise, I'm going to start with you on that one.
I think it's a lot of on the ground communication. And so we have kind of on the ground teams at each of the hospitals. We have, jackets or vests that have, the home hospitals, or we have pins that say, ask me about home hospital. I think that's one is on the ground. And then I also think the leadership bit, if leadership is bought in and talks about it and it's a priority, that also helps accelerate the process.
Kristin, one thing.
So I have to say, I have to agree with Denise. We have care coordinators, they're nurses, and they are our boots on the ground at all of our acute care sites, and they are interfacing, they're screening patients for hospital at home and care after discharge, but they're also interfacing with all of our specialists and our hospitalists and our nursing teams. So that has been mission critical in terms of just constantly keeping us and our programs top of mind for the providers and the staff at the sites.
Cool.
I really like that perspective. And the only thing I might add, Katie, is, 100% agree with the feeling that marketing is about the making of promises, and then our team executes against those promises every day. And so, just a huge shout out to our home hospital program team. Our top box recommend from patients this fiscal year has been 94%. That is really unheard of in brick and mortar environments. And that type of execution around excellence is the best type of marketing there is. And then the other part I might just add is becoming and being a part of the fabric of the institution. If our medical ICU or our surgical ICU suddenly disappeared, people would be like, holy cow, like they were great clinicians. We really needed them. Where are they? Like that would be a huge, huge issue. And I think that's how hospital home has to be. It has to be part of the fabric of the DNA, of the culture, of the health system, just intrinsically entrenched into everything we do.
Oh, amazing. What a great place for us to end. I know
Amazing.
everybody has other commitments to get to. Thank you so much for joining us, Kristin, Taki, Denise, Ben, thank you, of course. What a fabulous conversation. Hope everybody has a great day.
Thanks so much,
Thank
folks.
you all.
Bye.